Where is my screen?
Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. Today's session will be hosted by Dr. Izzi for internal medicine. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chat box, and they will be addressed.
I'm honored to introduce Dr. Farida Izzi. Dr. Izzi is an academic hospitalist and an assistant professor of medicine at George Washington Hospital in DC. She's the director of the fourth-year medicine acting internship clerkship at the George Washington School of Medicine and Health Sciences. She received her medical degree in India. Thereafter, she completed residency in North Carolina and a hepatology fellowship at Johns Hopkins University Hospital in Baltimore, Maryland. I would like to request Dr. Izzi to start today's session.
Hello, everyone. So I'm Farida Izzi, and I am a hospitalist at GW. I work as an academic hospitalist, so I'm involved in teaching as well as taking care of patients, clinical education as well. So I have both kind of roles. Are you able to hear me okay and see me okay?
Yes, it's perfect.
Okay, sounds good. So just a few disclaimers. I'm using some of the online videos and images that I found online, which are publicly available, but I'm also going to be using some information that is used at GW Hospital, like their EMR and things like that. So no copying, sharing of this video with anyone, and there's no external funding being provided for this presentation. All right, so I'm just going to go over a little bit about what we do as hospitalists and how I can entice you into becoming one. So first is, a hospitalist is basically a physician that works at the hospital. Okay, now in the past, what used to happen is that we used to have.
Excuse me, Dr. Izzi.
Yes,
you're not sharing your screen right now.
Sorry. What's going on? Sorry.
You're not sharing your screen right now.
Oh, hold on. What happened? Are you able to see the screen now?
Yes, thank you.
Okay. Okay. So basically, all I was saying was that as a hospitalist, what we do is we practice hospital medicine. And, in the past, what used to happen is we used to have primary care providers who would take care of their pool of patients. And if they got sick enough to require hospitalization, they would be admitted to a local hospital. So then that doctor would go to the hospital, take care of their patients in the hospital. And then when they were better, they would discharge them, right? So it worked out really well. Except that things started changing. People started, having more hospitals. People used to live further away. And then the doctor's schedules got busier. They now require to see like 25, 30 patients a day, depending on like reimbursement coverage, all that. So it became quite difficult for the primary doctor to be able to take care of their clinic patients, as well as go into the hospital and take care of their hospitalized patients. And then multiple hospitals came up and they would have to have privileges and apply for credentialing in multiple hospitals and then go and see patients in different hospitals. So it was just not like time efficient. So then we came up with this model called the hospitalist model, wherein there were physicians who would take care of patients primarily in the hospital setting. So they would take care of patients from the time they got admitted, take care of their whole hospital course, and then discharge them. And in the meanwhile, communicate with the primary care doctor so the doctor knows what's been going on with the patient. And this model seemed like it worked out really well. And that's how this hospitalist was born. And this is kind of what we are going to talk about today. This is an outline of who is a hospitalist, how you become a medicine hospitalist, what roles we play in the clinical setting, in the educational setting, in a research setting, what a family life is, how we have fun, and any questions you have. Okay, that's kind of the outline of today's session. Are you guys able to hear me and see the screen?
Yes, perfect. Thank you.
All right. This term hospitalist was initially coined by a physician at UCSF in 1996, and it's taken a huge rock and roll path through then, and now we've become like a major force of the medical industry. So mostly what happens is that the physicians we train, we do the residency in medicine, internal medicine, family medicine, and even emergency medicine. You can go through an MD and DO path, and then you do the work at the hospital. Now, what are the main differences of a hospitalist versus a primary care provider? Because the hospitalist is a physician who's at the hospital alone. We just have a short relationship with the patient during their hospitalization versus the primary care doctor who has a long-term relationship with the patient. But we give dedicated time to the patient during their hospitalization. So they have like dedicated time. We dedicate our time during their care. So we have a good relationship, even though it is short. We also we are good at treating emergencies, urgencies, because we do this on a day-to-day basis. So we are good at that. And then there is a hospital physician all the time, 24/7, versus back in the other days, in the olden days, where the physician would just be able to come for a few minutes to the hospital. And oftentimes the hospitalist also takes care of internal medicine problems, but the internal medicine physician cannot always take care of the hospital problem. So those are like the main differences between the primary care physician and the hospitalist physician. And I don't think anyone is indispensable. They all have their own roles, but they both work out great. But so that's the main thing. Okay. Now, in other words, you can say that we are equivalent to an house MD. I don't know if you guys have watched the serial before. It used to come a few years ago on Fox, but we may not be as egregious as house MD, but we may not be as smart as house MD either. But that is kind of the role we play. All right, so what is the path to becoming a medicine hospitalist? Before we start, I just wanted to tell you one thing. Every 20 minutes, we are going to take a quick fitness break for 1 minute so we can just deviate from the computer and do some fitness work before we come back, okay? So I'm going to start my timer now, and that way we can make sure we take our fitness break. So what is the path to becoming a medicine hospitalist? First, we, of course, need to do our school, and then we do an undergraduate bachelor's degree, then take your MCAT, then we do 4 years of graduate medical education at a medical school in US, and then complete the step 1 and step 2, then get into residency. And that's usually a 3-year training in internal medicine, family medicine, ER. Also, pediatrics has a hospitalist program. Some surgeons also have hospitalist programs, but our focus is going to be on medicine this time. And then at the end of it, we do an ABIM certification, which is the American Board of Internal Medicine certification. And that also is one of the required certifications for practice in US. And now we also have a fellowship in hospital medicine that's offered. And some people choose to do that. It's optional at this point, but I foresee that it's going to become mandatory in future. All right. So as a physician, as a hospitalist, what kind of activities do we do, right? So we evaluate patients, we obtain their history, we go over what their problems are, why they came in, we do a physical examination on them, then we order blood tests, urine tests, any other laboratory testing we do on them to make a diagnosis, right? And then we order any imaging tests like echocardiogram, EKG, chest x-ray, CTs, MRIs, all those things we order. And then if any procedures need to be done, then we request for those procedures to be done, right? And then how do we treat those patients? We treat them by prescribing medicines. We can do certain bedside procedures like aspiration of the knee joints, central line placement, which is an IV line placement. We can do ultrasound guided diagnosis, and also we can use ultrasound to do certain procedures. We also do like peripheral IV line placements. We can do nasogastric tube placements. We can do urinary catheter placements, things like that. And of course, an important thing is communication with family and educating the families and patients. Okay, so those are the main duties of a hospitalist. Now, there are different categories of hospitalists, right? So you can be an academic hospitalist like the way I am, because I also am involved in teaching. And then there are other private hospitalists who just come do their shift work and go. And there are different categories of shifts. So you can do a daytime shift, which is usually 7 a.m. to 7 p.m. And then you can do a nighttime shift, which is a nocturnist, which is 7 p.m. to 7 a.m. Some facilities also have an admitting hospitalist where the doctor just comes in between like 10 and 5 and does all the admissions, only the patients that get admitted to the hospital from the emergency room. And there are some physicians who also just do consultancy, wherein they just come, and if other services like a surgery doctor, orthopedic doctor, an OBGYN doctor wants a consultancy from a physician, then they just work as consultants. So these are all different kinds of shifts and categories that we play. Okay, but by and large, we are going to be talking about the daytime hospitalists because they have the most phenomenal role in this whole hospital medicine. All right, so what we are going to do today is talk about a day in the life of a hospitalist like me, how the day would start and what we go through in the day. And as I go through the day, I'm going to take you through different cases that I might see and go over a few things, okay? And in the meanwhile, we'll also have some fun cases, quizzes in the meanwhile as we go through the cases. And I'll tell you a little bit about how the structure of the hospital is and other things that we do, okay? We'll also have some videos in the middle. So join me on this rock and roll day. All right, so our day starts typically if we have a 7 a.m. shift, we are there at 6:45. We obtain the sign out, the handover from the night doctor. So there was a doctor who was covering the night. So we get a report from them as to what the events with our patients were that previous night. So we know what happened. Then we sit at our desk and then we review the electronic medical record and get our list of patients together. If we have multiple patients and have multiple hospitalists, we divvy up all the patients with the hospitalists, right? And then we get our list together, we review their overnight events, review the nursing notes, review the patient's labs, their vital signs, any imaging they had done, things like that. We get everything together. If there are certain things like patients have low potassium, low magnesium, blood pressure is high or low, all those things we can adjust with orders and medicines. So we type in those orders and send all those requests in the computer. We get everything together by 8:30, an hour and a half it takes for us to get all this together. Then at 8:30, we go around and start seeing all the patients. So we go room by room, depending on the wards they are in. Some may be on a neurology ward, on a medical ward, on a surgical ward, wherever they are located, we go and see them one by one. We talk to them, we talk to their families, we assess them with their physical exam. We then start writing notes on them on an EMR software. And then if any of the patients are done with their care and need to be discharged, then we create their discharge summaries and then get all their stuff ready for discharge. We also do interdisciplinary rounds with different types of providers in the hospital. So we have social workers, we have physical therapists, we have multiple other providers who also do integrated care with the patient. So we round with them also to make sure everything is sorted out. Some patients might have insurance issues. Some patients, when they're leaving, may need intravenous antibiotics, so that has to be arranged and the social worker will arrange that. Some patients, when they're leaving, are so debilitated that they cannot return home, that they need to go to a subacute rehab facility. So then we try to facilitate that also with the social worker. So things like that we do in the morning time. In the meanwhile, if we get a call from the ER and the ER doctor says, I have a patient that needs to be admitted, in the meanwhile, we would go down to the ER, usually it's on the first floor of the hospital. We go there, evaluate those patients, and then put in their orders for being transferred up to the floor. So all this kind of happens, simultaneously, and sometimes things are a bit haphazard depending on the flow of the patients and the workflow. So those things happen in the daytime, right? And then in the middle of this, if they give you an overhead call, rapid response to room 414 bed B, rapid response to room 414 bed B, then we know that something urgent is happening with the patient in that room. And if that is our patient, we need to rush to see them because it could be that they stopped breathing, they had difficulty with like a blood pressure reading, they had like a low blood pressure, or something happened, they collapsed, they fell, something urgent that the nurses needed urgent help, then we attend those rapid responses. And then we go evaluate the patient and see what needs to be done and take appropriate care. Sometimes if they code, like they don't have a heartbeat, then they may also need resuscitation. In that case, they upgrade it from a rapid response to a code blue. And then at that point, we might have to resuscitate them. We may have to call the anesthesiologist to intubate them, to put them on a breathing machine, things like that. So sometimes those things can affect the workflow, but that's something we participate in as well. Okay, then that's kind of the morning structure. Then from noon to 1, usually we have an educational conference, which is also with lunch. So we can eat and listen to the conference at the same time. So that way we get some education done and keep abreast with the latest happening in the medical field. And then from 1 to 6 or 6:30, we kind of finish up the rest of the things, complete the notes, complete the discharge summaries, talk to other consultants who may be involved with the patient, and things like that. Also, because I work in an academic center, we also have medical student didactics. We have their lectures, we have their workshops, everything in the afternoon. So some days those may be set up. So we might have to spend some time going to their conference rooms and doing their presentations and things like that. So that also takes up a bulk of the afternoon. The rest of the time, we also have some trainings going on. We need to do ongoing trainings on like risk management, how to do better coding, things like that. Those are on-site trainings that are needed. So we participate in those as well. So that kind of takes up the bulk of the afternoon. And then we prepare a sign out wherein we write all the details of the patient, and then we hand that over at 6:45 to the nighttime doctor. When they come in, we give it to them and we talk to them about the developments on the patient so that they can take care for the night. And the nighttime doctor mostly just does admissions to the ER and takes care of any urgencies that the nurse might call about. They don't usually see every patient. They are not required to. They only take care of triaging and urgencies. So that's kind of like in a nutshell how our day is, just so you know the workflow. Let's go on to the next thing. Now, so medicine, different categories, right? So medicine as such has multiple different divisions. So we have the heart division, cardiology, lung, GI, endocrine, hormone. We have rheumatology, which is bones and joints. We have nephrology, which is kidneys. We have infectious disease. We have allergy, immunology, heme-onc, which is cancer, radiation oncology, which is cancer, radiation therapy for cancer. We have critical care, who take care of ICU patients, palliative care, which is end-of-life treatment, psychiatry. We have radiology. Then we have interventional radiology, who are doctors that look under radiology and do procedures. We can work as a consultant. We don't do deliveries. We don't do big surgeries, which require anesthesia and things like that, but we do small procedures. So these are like the main divisions, and we work closely and we take care of patients of multiple categories. Okay, so these are the main divisions. And I'm going to try and make sure we cover all these cases in this presentation. So we're going to go fast. Okay, so pay attention and let's get started. We're going to start with an infectious disease case. So this is a simple case, 55-year-old lady who had a history of diabetes, high blood pressure, high cholesterol, and obesity, who came in with some leg pain. And she had leg redness, swelling, localized pain, some fever. And when we examined her, we saw that her leg was red like this. And then we did the demarcation, so we know exactly where it is, so we can assess for improvement, okay? And she noted that she recently had an athlete's foot infection and had some break in her skin in her toes. And then we saw this. We did some blood test on her, and the blood test showed leukocytosis. Now, you're going to be coming across this word a lot in my presentation. Leukocytosis basically means increase in your white cell count, which is suggestive of an infection. So this patient had a leukocytosis of 15,000, and the normal levels are less than 10. So hers was slightly elevated. And her sugars were a little bit out of range, but not crazy. It was 138, blood pressure was fine. So what was a diagnosis here? Our diagnosis was cellulitis. Cellulitis, it is infection of the skin and subcutaneous tissues of the leg. It's a very common presentation in medicine. Many times it can be treated as outpatient, but if they get a high white count fevers, then sometimes they have to be admitted. The cause of this is usually a break in the skin of the foot from which the bacteria enter. The usual bacteria are Staph aureus, Streptococcus, and you usually see leukocytosis, redness, and there are risk factors like diabetic and obese patients tend to get this more than others. But anytime we have a diagnosis, we always have to think of what else it could be, right? So we always, in medicine, we have to have a differential diagnosis. So you need to know, if it's not cellulitis, what else could it be? So in this case, other things we would think about would be an allergic reaction, vascular disease, Raynaud's phenomenon, erythromelalgia, all these other things. But the scenario fit best with cellulitis, but we did give other things a consideration. The treatment is usually with intravenous antibiotics. So this patient got intravenous vancomycin. We also elevate the leg. And then how do you prevent it from happening? Prevent skin injuries, maintain good foot hygiene. The complications that can happen with this are recurrence of cellulitis. Once a cellulitis, they always keep getting it. So that's something. And then also it can go on to an abscess formation. So basically, for every condition we have in medicine, we want to know what is the cause of it, what are the bacteria or what else is the causes it, what are the clinical features that go with it, How do you make a diagnosis? What could be an alternative diagnosis? How do you treat? What are the complications and how to prevent it? So for every disease, this is how it's going to be. Now, of course, we don't have time to review everything about everything, but this is kind of how we think about every disease that the patient has. And then, of course, we need to write notes. So this is, doctors, they may not have the best handwriting, but of course now it's okay because we have the electronic medical records. So now you can't run away. You still have to write it. I mean, you still have to type it. And this is just an example of what an H&P form is like. So when a patient comes in, first they have a chief complaint, and then you put that complaint in. And then if they have a main reason that they're coming in, that is what you explain in the history of presenting illness. Then you go over their past medical history, surgical history, what allergies they may have, and the reaction to the allergy. Like, so for if they have a penicillin allergy, what is the reaction to it? Do they get hives, rash, whatever? Medications, when they started it, what is the dose? What is the frequency? What is the reason for it? Social history, who do they live with? What hobbies they have? What pets they have? What do they drink alcohol, do drugs, anything like that? Family history, any medical problems that run in the family that could have a bearing in the patient. The other thing that's very important is review of systems, because sometimes patient may complain of one problem, like say, for instance, they have a fever, but they may also have some joint pains, which they may not be forthcoming about, but they will ask you if they are prompted and you ask them, do you have joint pain? They might say that, and that might be a reason why they have fever. So things like that, the review of system helps with, okay? So this is the history and physical exam part of it. We get this from the patient. Based on this, we make an assessment and plan as to what could be going on with them and what you're planning for them. And then there's also the section of care maintenance, which is important for hospitalized patients, because in hospitalized patients, we have IV. So the IV needs to be maintained. They're laying on bed, so they may get bed sores. That have to be looked at. They may have diarrhea or some antibiotics, which cause some complications that have to be looked at. Since they're laying in bed all the time, they may get blood clots. So we got to give them medicines to prevent blood clots. So there are a set of things that we follow as hospital physicians that help for care maintenance in these patients. So that's something we also do. So that's kind of like an overview of how we do it. Now, I'm just going to show you what the EMR looks like very quickly using a GW EMR software. So this is a YouTube video that I've just downloaded, but I cannot expand it in this session. So you're going to have to look at it in this short view. So this is called Cerner. This is the power chart Cerner. When you open it, it opens up to a message center. And this is the list of my patients that I have. So this is the message center. I have no messages right now. This is the list of patients that I'm going to be having, and it's assigned to the doctor and things like that. When you open up the patient's chart, you have different tabs. So one tab is a vital signs, which shows the temperature, heart rate, blood pressure, and things like that. Then the next tab is the results laboratory tab, on which you can look at the patient's like blood counts and urine tests and other lab tests that are done. The next tab has the imaging, and on the imaging, you can see different x-rays that could be done, the EKG that was done, things like that. Also, other imaging I'm going to show you on the right-hand side in a little bit. The other tab that we also have that we use frequently is the documentation. In the documentation tab, we write the notes, we write all the history and everything. And it can have the ER notes, it'll have the physician notes, it'll have the physical therapy notes, it'll have the social worker notes, everything. So we review here and we also document here. Okay, so that's kind of an idea about what the Cerner is like. Then we are going to review, now say for instance, this patient that we were reviewing was a 72-year-old gentleman, but a history of diabetes, hypertension, who came in because he was not able to see from one side of his face. This whole side of his vision was obscured. And he also had weakness, was unable to talk, and had difficulty swallowing. So when he came in, there was concern for a stroke. And so we did an MRI. We did a CT scan. The CT scan didn't show much. We did an MRI of a brain, which is the magnetic resonance imaging, which is basically they go into a cylindrical tube and they are placed in there. And you are standing, you have to look at it. When you look at the images, you're going to look at it as though you're standing on the tail end of the patient, on the foot of the patient. And the images are cut like in slices, So the imaging that we're going to look at now here is going to be the image that's cut at the slice of the eye, okay? Those are just the slices that they cut when they're taking the images. So if we look at this here, this is an image of the brain at the level of the eye. You can see the eyeballs. And then here you can see at the back is the cerebellum. And in the cerebellum, you can see a white dot. I don't know if you're able to visualize it, but that white dot is where the patient had a brainstem infarct. And this is the same different images of the same section. So you can see in that there is a white dot here, which is the brainstem infarct. Now, this patient, because they also had difficulty swallowing, we did a swallowing study, and this is an image of that. If you look at this particular image here, you can see the patient trying to swallow some liquid, and you can see how the food is going through it down, but then it doesn't go beyond it. Like the patient's not able to gulp it down. It stays, and then it stays, and it stops here in the throat. It's not able to go beyond it. That's because this patient had difficulty swallowing and then ended up getting a stomach tube placement called a gastrostomy placement. But that's kind of how we view the images in this thing, okay? All right. So let's take a quick break now, a 1-minute break. Go out, look outside the window, blink 20 times quickly, and do 10 push-ups, 10 jumping jacks, and I will see you back in 1 minute, okay? I'm going to do the same thing myself. All right, guys, are you back? Okay, we are going to continue now. So does an apple a day keep the doctor away? What's your thought? Well, only if you aim it well enough. Really, the apple is a healthy fruit, but it has a lot of sugar, okay? So you got to be careful. But you can't eat the apple. All right, let's go on to the next case. Next case is a case of a GI case where a 75-year-old man with a history of some psychiatric problems, bipolar and major depression, also had Parkinson's disease. He came in because of severe depression. He was not eating, not drinking, was staying very aloof, not sleeping well. Family brought him, and there was concern that he was failing to thrive. And he was admitted to the psychiatry department. And there they noticed that his blood pressure was staying very low. He had a lot of diarrhea. So they consulted the medicine doctors to see what was going on. We tried giving him some intravenous fluids, but he did not improve. So then we recommended that he be transferred from the psychiatry department to the medicine department. And that sometimes happens too when patients are admitted to one service, but then you realize maybe they need to be on a different service. So then we transferred him to medicine. And then he continued to have some abdominal pain, and his blood work showed leukocytosis, which means infection, right? Concern for infection. So then we did some testing on him. We did an abdominal x-ray, and that abdominal x-ray here, you can see this is the large, but the small bowel and the large bowel, it is very enlarged. So this is a large bowel host tray. That's how you identify that this is a large bowel, and they were quite swollen and enlarged, and we were concerned that he had an infection. Incidentally, I don't know if you can see this here, but there are some small things here. That's the gallstones. That was just an incidental finding. But because we saw this, we were concerned about an infection. So we did a CAT scan. So I'm just going to show you the image of the CAT scan. So the CAT scan is basically like how the MRI is a cylindrical tube. The CAT scan is just a circular machine, okay? So it's just a circular small column. You just go through that and come out. And this is very easy to do. It's done very quickly. This study was done with intravenous contrast, okay? And this is an image at the level of the abdomen. What you're seeing here is the intestine, and it is thickened. You can see that the intestine is thickened. And this is here the stool in the colon. Okay, so that's how we diagnosed that he had colitis. So let's take a quick view of this. And you can see here that the colon is thickened, and there is, other things here. This is the bones and other things, but that's the colon basically, okay? So with this, we made the diagnosis of colitis, rectosigmoid colitis with increased stool burden. We did his stool studies. We tested his sample of stools. It did not show any infection. He was then treated with intravenous antibiotics, ceftriaxone, metronidazole, and then he also got treatment for depression. And he started to improve. He started to eat better. He had good bowel movements and blood pressure improved. And then we had the physical therapist come and evaluate him. They worked with him. He got a little better, but he was still quite weak and he was not able to walk on his own. So they recommended that we send him to a subacute rehab unit. We worked with a social worker, arranged for him to go to a subacute rehab unit, and then he was discharged. So that was this patient, okay? Next patient, so we're heading to. Before that, on the way, we have a question. What's the condition of the boy who swallowed the quarter? No change yet. All right, next patient we're going to. This is a young guy, okay? He's 35 years old. His mom sent him because he drinks too much alcohol and his mom wanted him to stop drinking alcohol. So his mom sent him to the ER. He was not interested in coming. Anyway, when he came in, he was noted that he had a very high heartbeat, was very restless, was agitated, tremulous, and then he started craving for more alcohol. His heartbeat was high. We could not discharge him. We had to admit him. And so we started giving him some medicines for sedation so he doesn't feel the features of alcohol withdrawal, the cravings, but he kept asking to be discharged. Ultimately, he agreed, he was admitted, and we had an observer in his room because many times these patients, they run away, they disappear, they elope. So we had an observer in his room, so he didn't do anything like that. So the observer noted that the patient was going to the bathroom repeatedly. And she was like, okay, because he was getting IV fluids as a treatment for the alcohol withdrawal. So she thought maybe, he just wants to urinate. And then one time she went into the bathroom after the patient came out and she saw that in the bathroom, there was a bag with huge bottles of hand sanitizer. And the patient was actually drinking the hand sanitizer to curb his cravings for alcohol. Interesting things happen, right? So, but anyways, we caught it, we confiscated it. He was upset about it, but then he came around, treated him with IV fluids, gave him multivitamins. In the IV, we, especially thiamine, which is often lacking in patients with alcohol use. We repleted his electrolytes. He had low magnesium, low potassium. We repleted all that. Then he got better and then he was discharged, counseled him. So that was an interesting case of alcohol withdrawal. So you always got to check their belongings. You never know what might be hiding in there. All right. Next patient we're going to is a patient who had abdominal pain. So this patient also had some psychiatric disorders, schizophrenia, bipolar, was not eating much recently. And he came in with abdominal pain, vomiting, and an inability to eat food. His vital signs and everything was okay, but he was just not able to keep food down. So then we did basic labs, they were okay. And then we did an x-ray of the abdomen. And guess what we saw on the x-ray? We saw that he had swallowed a spoon. Can you believe it? He had swallowed a steel spoon, and that's what was showing up in the x-ray. And that explained. Now, this is a problem because this can block the passage of food. It can block the exit, the duodenum area where it can block and cause an obstruction. So what did we do with this now? We call this GI doctors, so stomach doctors. They came in, they did an endoscopy on him, and then with endoscopy where they put in a tube down your mouth, your throat, it goes into the stomach. It has a camera at one end, and then at the other end, you can also insert another scope through which you can go and retrieve the spoon. And the GI doctors, they were successful in repleting it, in removing it. So they removed it, and then the patient was monitored for a day or so, was stable, and then was discharged. And so we have to be careful with this because patients can swallow anything, especially patients that have psych disorders, sometimes have no control over their thoughts. So that becomes an issue. But anyway, this patient recovered and then was discharged. All right. Next, we're going to go over a psychiatric case. Looks like there's a lot of psych going on, right? Nowadays, we see a lot of psych cases also. And many times it's an underlying problem. So this is a little complicated case. I'm just trying to give you a variety of cases so you can see how sometimes things could be simple, sometimes things could be complicated. So this patient was a 73-year-old lady who spoke a Kenyan dialect. She had a history of paranoid schizophrenia, and she was on intramuscular Haldol for this for many years. And she kept coming in because of recurrent pneumonias. And recently she was also admitted with a COVID infection. But now the family had brought her in because 3 days she'd been confused. She was unsteady. She was having incontinence in her urine. She was not able to hold her urine, and she was just diffusely weak. Patient was not able to give us any history. And when we examined her, we saw that she was very rigid. She was very tight, not able to extend her arms or not able to flex her arms. She was very tight. And so when we did her labs, we saw that her muscle enzymes were very elevated. CK is creatinine phosphokinase that was very elevated. So we knew that there was some muscle involvement. Also, she had very high fevers, 103. Blood pressure was low. So we were concerned with all this, her inability to, talk, and was unresponsive. We're concerned that she might be able to protect her airway or not. And sometimes these patients stop breathing. So she was monitored in the ICU, and she did not have any problems with the airway. But the one thing we noticed was she had received Haldol medication, and Haldol medication oftentimes causes a syndrome called the neuroleptic malignance syndrome. And that syndrome is characterized by high fevers, rigidity, and she had recently received the Haldol medicine. And many patients get Haldol, it does have some side effects, but this patient had gotten a depot Haldol. She had gotten the depot Haldol medicine. And the depot Haldol is a medicine which lasts for a prolonged period of time. It lasts for a month and a half, so that patients don't need to take it every day. They give them a Haldol shot that lasts for a month and a half. So this lady had this medicine that we were not able to remove from her system, and now she had adverse reactions of that medicine, this neuroleptic malignance syndrome. So then we started her on this medicine called bromocriptine and dantrolene. The bromocriptine works against the dopamine receptors in the brain. It works to promote the dopamine and helps in relaxing the muscles. And dantrolene also is a muscle relaxant. So we use these medicines to try to get her to relax until this Haldol wears out from her system, which could take about a month and a half. And she had just received it 2 weeks ago. So that was a bit of a challenge. Finally, she got a little better. And then after the ICU, she was transferred to the floor. That's when we started taking care of her, because we don't take care of ICU patients. We take care of only floor patients. So once she came to the floor, we started taking care of her. Her rigidity improved a little bit, but not so much. She was still rigid. In the meanwhile, she had an IV line. And near that line, she developed a big clot, like she developed swelling in her arm. When we did an ultrasound, we saw a clot there. So then we started her on blood thinning medicines. Also, she was very malnourished. She couldn't talk. Her mouth, everything was like rigid and could not move. So she was not able to eat. It was a week when she ate, so that was another issue. The third issue that came up was because she was just lying in bed, not moving around much, and she had the urinary incontinence where she was not able to hold urine. She developed a urinary tract infection. One day we noticed that she had high fevers, low blood pressure, her white count went up. And then when we did the testing, we found that she had a urinary tract infection. So this is just to show you the patient came in with one problem, how multiple problems come up in the hospital, and we have to treat them as they come along. So for the blood clot, she was started on blood thinning medicines. For the urinary tract infection, she was started on antibiotics. And then, her rigidity did not improve. So we repeated a course of dantrolene. And when we repeated the course of dantrolene and bromocriptine, then she started to improve. In the meanwhile, she had stopped eating and she was malnourished. So we had to put in a feeding tube down her nose. It's called the nasogastric tube, which is a tube we put down the nose to help with her feeding. This is just a quick video to show you what the feeding tube looks like and how you put it. Of course, this patient is awake and able to cooperate, but our patient was not able to cooperate. So you just put it down the nose. It's a thin tube and it has some weight at one end. And when it goes down the nose, you ask patient to swallow some liquid. And as they swallow the liquid, you keep pushing that down so it goes down the right path. That's just to give you an idea of what the NG tube is like. So that was placed. And then we do an X-ray to confirm the placement of the NG tube. So this is a chest X-ray. And this chest X-ray shows the clavicles here, which is the collarbone. This is the rib cage. And these are the different ribs. Black stuff is the two lungs, right? These are the two lungs and the middle is the heart. And this is the aortic knuckle. These leads are the EKG leads. But what we are mostly looking at is this nasogastric tube, which has come down here. And you can see following it here, it comes here, and then it ends in the stomach. This is the weight at the end, which keeps it in position. So this is the nasogastric tube, which is in position. And then we fed her, we started feeding her through liquid feeds called tube feeds. And then she got better. And then eventually she was discharged to a subacute rehab facility because she was still quite weak at discharge, but her strength and everything got better. But it took about a month for her to get better overall. So that was this patient with psych. Okay. So just a quick question. Do you know, I don't know if any of you have been to a psychiatry floor, but when you go there, you will see that the floors and rooms are fully empty. And I had once an interesting case of a patient who was constantly on home oxygen because she had a lung disorder called interstitial lung disease. And when she came into the hospital, she tried to strangulate herself with this nasal cannula tubing that you see here. She tried to strangulate herself with that because she was so suicidal. So sometimes it's very difficult with these patients where you have to constantly monitor them so they always have cameras in their room or they have an observer in their room. Some other things that they might do is try to run away. They might just disappear when nobody is looking. They sometimes try to jump out the window. So you always will notice that there are bars on the window, and they don't have any furniture except a bed in the room. And even the room has a little cutout, so you can go into the room even if the patient does not open the door. And also, you don't give them steel utensils, because remember, we saw that case patients swallow their steel utensils, so no steel utensils for them. All right. You ready for the next case? The next case is a combination of endocrine, infectious disease, and a foot problem, okay? So this is a 71-year-old Spanish-speaking male with diabetes who had complication of diabetes like diabetic neuropathy, foot wounds, had a partial foot amputation, alcohol use for many years, tobacco use, and he came in with altered mental status. He came in confused, was not responding. Family brought him in. When we did the labs, we saw that he had a high buildup of acid. His pH was low, and he had significant acid buildup called metabolic acidosis. And his glucose levels were very high, 800s or so. Normal levels are usually less than 120. So his was quite high. Also, he had spilling of glucose and ketones in his urine. So he was diagnosed with a condition called diabetic ketoacidosis, and he had to be monitored in the ICU. So he was admitted to the ICU. He was given intravenous fluids. He had to be given insulin in the IV in the form of a drip, like continuous insulin for a few hours, till the acid buildup could reduce. And then he improved. And then the insulin was transitioned from the IV form to just a subcutaneous injection form. And then he was transferred out to the floor. And that's when we started caring for him. When we came to the floor, we noticed that he had a huge foot wound. And we could even see the bone of the foot, which meant that the foot infection had gone into the bone. And that's when we diagnosed osteomyelitis, which is an infection of the bone. And remember, bone is a hard tissue. It's very difficult to penetrate. So the treatment is prolonged and very powerful. So we did cultures of his wound. He grew Klebsiella, Staph aureus. We started him on intravenous antibiotics, napsilin, ceftriaxone. We consulted the foot specialist called the podiatrist, who's a foot surgeon. He went and cleaned up the patient's foot, and the patient did require more amputation because the bone was involved. And this is what the foot would look like in the beginning when the patient came in, and this was all like the infected area. And then the patient ultimately underwent the resection. And then this is the healed wound after everything worked out. But in the course of it, the patient had to receive the intravenous antibiotics for at least 6 weeks. And we had placed a long line called a PICC line, which the patient can be discharged with, and that patient can have that line when the patient goes home. So that patient received that. We contacted our social worker team who arranged the intravenous antibiotics for the patient, and the patient was discharged. So that's kind of how that worked out. But bone infections are hard to treat. Another quick break here, question. What do you think is the answer for this? These are 4 things. There's only one sentence which is right, and you got to tell me which one is right. The veins are concerned with the way they look. Arteries like to spend their time painting. Arteries kill and veins promote life. Or do veins carry blood to the heart and arteries carry it away from the heart? Which of this is true? I'm sure you all know it's the 4th one, right? Next, we are going to talk about a patient who had a skin condition. So we entered this room of this patient next, who has these skin blisters. You can see these are huge skin blisters. And when you first look at it, you think that this person has a serious disorder of the skin. And the story is that this patient actually was a 62-year-old male. He had a history of alcohol use, and he was found down by the police on the street in cold weather. And he was lying there for like many hours, looks like. He was totally unresponsive. And when we found him, he was found to be in sepsis, had infection with aspiration pneumonia. Now, aspiration pneumonia is something we see often in patients who are unresponsive, because we're unresponsive, you know, their spit comes out and then they inhale the spit. So the spit goes into the lung and then it causes infection. And that's what we call aspiration pneumonia. So this patient also had this aspiration pneumonia, and then we started him on antibiotics. But also we noticed that the skin had these lesions. So when we look at these lesions, the things we have to think about are going to be like some kind of severe blistering disease. And common blistering, significant blistering diseases are bullous pemphigoid, pemphigus vulgaris, things like that. So we were concerned about this. We called the skin doctor. It turns out that these were actually coma blisters. These are just blisters from lying on a hand for a prolonged period of time and actually causing skin denudation. So these were actually coma blisters. And we observed it for a few days, made sure it didn't get worse. And then the skin doctor actually nicked one of the lesions here. You can see that it was nicked. They unroofed it and all of them flattened out, and then the patient improved. Subsequently, we realized that the patient had had difficulty breathing. And then we found out, we did a CT scan of his chest, and then we saw that he actually had some blood clots in his lung. From lying down for a prolonged period of time, he had developed blood clots in his lung, and that's why he was short of breath and his heartbeat was rapid. And then he was started on some blood thinning medicine. So blood clots in the lungs are another bane of our existence because they happen anytime and it can kill you. So anyhow, this patient got better, and then the patient was discharged again to a rehab center because he was very weak. And he vowed that he would never drink alcohol again, but let's see. All right. So are you a pulmonary embolism? Because literally you can take my breath away. It's one of my favorite songs. All right. So next, go on to a lung case next, okay? So this is a 48-year-old patient with diabetes, high blood pressure, and has lupus, which is a disease in which your immunity reduces. Also, the patient is on prednisone, which is a steroid, because of which also your immunity goes down. And this patient came in with shortness of breath, cough with some sputum production, and had high fevers. When we evaluated the patient, we saw that the oxygen level was very low, had hypoxia, was breathing very fast. And the lab showed leukocytosis again, which was infection, and also had some kidney issues with kidney injury. We did a chest x-ray, and the chest x-ray showed a pneumonia. So this is what a pneumonia looks like. Like a normal chest x-ray needs to have black lungs. Here you see this white area, a wedge-shaped area, and this was concerning for a pneumonia. And if you look at the similar thing on a CAT scan, remember I showed you the other CAT scan also. So this is the lung image of the CAT scan. So it has to be full black on both sides, which is air. And these are all the little blood vessels. This is the heart. This is the spine, the vertebra, and this is the rib cage, right? So this is the lung that we are seeing here, the same thing we're seeing here. And it's as though this is the right side of the patient, this is the left side of the patient. And this is what it looks like, right? So we started this patient on intravenous antibiotics, ceftriaxone, azithromycin. We gave her some nebulizers. We gave her oxygen support. We also gave her some decongestants. We also had to continue the steroids because this patient had been on steroids for a long period of time. Not good idea to abruptly stop the steroids. So we continued the steroids, and then the patient improved. And then before discharge, we gave the patient the pneumonia vaccine, because then that way it can prevent them from getting pneumonia again. And then ultimately the patient improved and was discharged home. This patient was found to have streptococcal pneumonia. So it was a very simple type of pneumonia, luckily, but sometimes they get much complicated pneumonias. So that is a lung case, okay? And I just want to show you how different pneumonias are different. So this is a patient we had now, like who just had a regular pneumonia. And this is a patient who has a TB pneumonia. You can see a little cavity here. And this is what it looks like when you do a CT. It has all these cavitation formation. This is tuberculous pneumonia. It's a very contagious condition, often seen in patients who are immunosuppressed, who are in jail, who have other immunosuppressed conditions like HIV, and also people who come in from places where it's endemic, like India. So we see this a lot. Causes cavitation necrosis, and it is contagious. So they have to be kept in isolation rooms, much like the COVID patients. And also this is treated with like a 6-month drug regimen of 4 drugs. And it is so contagious that actually the Department of Health will come to your house and make sure you take your pills every day. So it's a pretty serious condition, TB pneumonia. Just something so you know. All right. Ready for the next case, guys? Okay. This case is an interesting one, bleed and cancer. So this is a 56-year-old male, came in with, he has a history of heart disease and high cholesterol, had some hernia before. He came in because he kept fainting, had weight loss, had weakness. And then when he came in, he also said that he had some maroon stools and some black stools. And we noted that his hemoglobin was 5. Normal hemoglobin is between 12 to 14. His hemoglobin was 5, and he had no history of bleeding in the past. So then we were concerned that he could have a GI bleed. So we called, we did give him the blood transfusion for his low hemoglobin, but we did call the GI doctor to see where he could be bleeding from, and maybe he needed an endoscopy, colonoscopy. So that's what we had done. He got the upper endoscopy, which showed a gastric ulcer, and that also had some bacteria in it. So we started him on treatment for the ulcer and for the bacteria. And that is what the ulcer looked like here. You can see this is the ulcer with a white base. So it didn't look like it was bleeding from here because it was a white base and it didn't have any active bleeding noticed. So then we also did a colonoscopy because of that. And this is what the colonoscopy showed. It showed some areas where there was one area which had a small nodule, another area which had a bigger nodule, and another area which looks like this, which is really bad. And this is suggestive of cancer. So this patient actually had colon cancer. And this biopsy showed that he had stage 2 colon cancer. His CEA level, which is a carcinoembryonic antigen level, which is a marker in the blood for colon cancer, that was elevated. And then we did a staging CT scan. We did a CT of the whole body to see if there was any spread. And we found that he had stage 2 cancer. So then we called the stomach, the GI, the intestine surgeon, the colorectal surgeon, who did a surgery on him, removed that portion of the colon. And then we also consulted the medical oncologist doctor, who started him on chemotherapy with a regimen called FOLFOX. And that's like some fluorouracil and leucovorin and oxaliplatin chemotherapy. And then some of it was done in the hospital. The rest was followed up as an outpatient. And that's how the patient was discharged. All right. This is another fun case, sometimes seen in psych patients. Do you know what this might be? This is called a bezoar. Okay, sometimes psych patients, they swallow bizarre things like hair, fiber, teeth, other things, just like that patient who swallowed the spoon I showed you earlier. And these things, they finally collect over time in the stomach and they become a big ball. And then they block the passage of food in the stomach. It's called the trichophytobezoar. That's what this patient had once. We had this patient and ultimately we had to go make this into pieces and then extract it. So sometimes there's fun, but little odd things happening. All right. Next case is an allergy case. So this patient, actually, my alarm just went off. So let's take a quick 1-minute break, go outside, look outside, blink 20 times, 20 jumping jacks, and I'll see you back in a minute. Okay? Okay. Are you guys back? We still have a few slides to go through, so I'm going to go a little fast, but we still have interesting patients. Next is an allergy case. So this lady came in, she had a history of hypertension, and she's been taking this medicine, lisinopril, for a prolonged period of time, but now comes in because she had fullness in the mouth, some difficulty swallowing. And we noticed that she noticed that her tongue was swollen. And then over time, her tongue kept swelling more and more to the point that then it caused airway obstruction and she could not breathe. So she was sent to the ICU and she was intubated. They put a breathing tube down her throat to help her breathe better. And she was also given medicines like epinephrine, which is an allergy medicine, and also steroids, which helped to reduce the swelling. Eventually, she got better. She came out to the floor. We took care of her and we advised her never to take steroids, never to take lisinopril again. Lisinopril is a medicine used for blood pressure, which is notorious for causing angioedema. This patient had a condition called angioedema, which is a life-threatening condition. She cannot use lisinopril again. Okay, some good habits, you guys. I'm sure you guys have it, but some habits that I've seen make successful students are when they're intellectually curious. Always be curious, ask intellectual questions, never stop thinking, don't buy what others try to sell. Only buy it if you think it makes sense. So use your own judgment. Always self-reflect at the end of the day, helps you become much better physicians, stay active, and always make sure you have fun. So schedule your fun time along with your work time. And checklists are a must for all kinds of physicians because everything needs to be done for every patient and nothing can get missed. Otherwise, it can take life away. So checklists are a must. All right, next we're going on to the important topic, the heart. So heart, I'm sure you guys all know, has 4 chambers. Okay, this is a nice representation. So you have the right atrium, right ventricle, left atrium, left ventricle. Blood comes in from the body and goes into the right atrium, goes through the valve, comes into the right ventricle, goes into the pulmonary artery, goes into the lungs, gets oxygenated, clean blood, comes in from the lungs into the left atrium to the left ventricle, and goes into the body through the aorta, which is the biggest artery in the body. Now, this is called the veins which bring it to the heart are called the SVC, IVC, brings it in. This valve is called the pulmonary valve. I'm sorry, this valve is called the tricuspid valve. It goes into the right ventricle, goes into the pulmonary artery, which has the pulmonary valve, and then goes into the lungs, comes in back from the lung, comes here through the mitral valve, and then it comes into the aorta. Here is the aortic valve. Okay, and then it goes to the body. So this is the heart, and this is a more complicated picture. I love this picture. All right, let's go through a cardiology case now. So we have a 50-year-old lady who has a history of already some cardiac disease called dilated cardiomyopathy for 5 years, and she's on medications already, but now comes in because 2 days ago, her shortness of breath has just been getting progressively worse. So first we thought she might have a heart attack, so we did cardiac troponins, which were negative. Then we did a BNP, which is a test. It's brain natriuretic peptide, which shows you if there's a stretch on the heart and if there is some heart failure. And hers was quite elevated. Normal is like less than 100. Hers was 16,000. So she did have significant stretch of the heart causing heart failure. And so we did a few other tests like an EKG, chest x-ray, and echo, and I'll show you what that showed. So this is a normal echocardiogram. All the waves are like this. We don't have time to go over all the different waves, but this is a normal echocardiogram. In her, we saw this, which were deep waves in deep S waves in V1, and all this here also. This is a typical left bundle branch block, and this indicated that there was some problem in the electricity of the heart. All right. And then we also did the next, which was a chest x-ray. Remember, I showed you the normal one. This one shows that she has huge fluid buildup everywhere. This is called interstitial and alveolar edema. This is a normal x-ray, just so you know, for reference. And just how the edema builds up. First, there's no edema, then you get a little bit of congestion. This is more interstitial edema, and this is severe alveolar edema. All right, and this case, so then the other thing we did was a cardiac echo, and I want to show you the findings on the echo. Here we are going to see a mitral valve here, and you can see the valve just needs to bring the fluid in the blood in one direction. But here you will see that the blood is not just going in one direction, but because this valve is incompetent, the blood is also going in the other direction. And that's one of the main problems this patient had. So I'm going to show you this video. Let's look at it quickly. It's just a few seconds long. So this is the valve, and you can see the blood is flowing through both directions. It should be only going in one direction, but it's going on both directions because the valve is incompetent. So this patient had a condition called mitral regurgitation. All right, and basically this patient, she had worsening heart failure with mitral regurgitation in the background of the cardiomyopathy that she already had, and her pumping was only 20% that of normal. Because of this, she needed to get a pacemaker, and she had a pacemaker implanted. And even though she had that valve problem, because of her low heart function, she could not get surgery. And we just treated her with medicines, and then she was discharged. And because heart attack is the most common condition, most of the heart attacks go to the heart doctor's team. But I just wanted to emphasize that these patients come in with chest pain. We check their vitals, we check their oxygen levels, and then we check their troponins, which is an important marker of damage to the heart. And we check their EKG, we check their chest x-ray. So this is what the chest x-ray looks like in a patient who has a significant heart attack. You can see that all these waves are up. All this is bad stuff. It shows that the heart has been damaged. And this inverted T's here, this is also the significant finding. So this patient did have heart attack. And the main treatment is, aspirin. We know that everyone needs to get aspirin, but the mnemonic we use is MONA, that is morphine for pain, oxygen, nitroglycerin, which helps to dilate the blood vessel, and aspirin, which helps to keep the blood thin. We also use some beta blockers, ACE inhibitors, and lipid lowering agents. It's okay if you don't understand those. And then we start them on a heparin drip, which is a blood thinning medicine. So that's what it needs. And then we call the cardiologist, and then they go to the cardiology lab. All right, next case, we're going to talk a little bit about animal hazards. A fun case we had. It's a 53-year-old male who came in with abdominal pain, some nausea, diarrhea. And of course, first concern was that the patient had gastroenteritis. And then we did some labs, and the labs, we noted that the patient actually had acute hepatitis A, which is obtained by eating tainted food. And then further questioning showed that this patient was actually running a dog walking business, and he would take dogs out for a walk and pick up the dog poop with the bare hands. So you know where he got the hepatitis A from. So the important thing to remember, always wash your hands. All right. Next, another infection case where we had a patient with 55-year-old with diabetes, hypertension, came in with fever, neck stiffness, headache, and we found that his temperature was high. Again, he also had an infection, and there was concern that he had a spinal infection, meningitis. So then for that, we do a procedure called the spinal tap. I'm just going to show you quickly what that looks like. You inject, this is the back of the patient. You inject some lidocaine as pain medicines. You do a sterile drape, and then you put a needle in that area in the spine, and then we obtain the fluid from the spine. So you have to make sure you don't affect the spinal cord. And here, if you look closely at this area, you can see the fluid falling down. That is the clear spinal fluid. And then we send it for testing. And then in this patient, we found that he had a condition called cryptococcal meningitis. Sorry. We saw this condition called cryptococcal meningitis. We had a high fluid pressure in the brain, and he had these typical characteristic cells, which is characteristic of this disease. But we also found out that this patient had a new diagnosis of HIV. And this is a condition that is often seen in patients with HIV. It has a very rigorous treatment. It's a fungal infection, so it's treated with all these antifungal medicines. And then he was also started on treatment for HIV. So that's something unusual, but we do see this and other kinds of bacterial infections, streptococcal meningitis, and other kinds of meningitis. This is just a fun case we had seen. All right. This is another patient. This was another fun case we had. So this patient was an obese gentleman who had obstructive sleep apnea, where he would, whenever he would go to sleep, he would start snoring, can't sleep, would wake up, and he had obstruction to the flow of air. So he used to be on this CPAP, which is a continuous positive pressure. So every night he would sleep with a machine that helps put air into his lungs and increase pressure in his lungs. For this procedure, he had a procedure called septoplasty done, so that helps with it. After septoplasty, you should not use that machine. But he accidentally used that machine. Because he used that machine, it forced air into his nose, into his face. And because the septum was removed because of the surgery, the air went directly into his brain. And then when he came in, he was confused. And we were trying to figure out why he's confused. And his family told us he recently had the surgery. And we did an MRI of the brain, and we saw this interesting finding for tension pneumocephalus. It's called Mount Fuji sign. It looks like the Mount Fuji, the Japanese mountain, which is very popular. Used to erupt volcanoes in the past. So this is a cute sign. I just thought I'd share it with you. But the important thing was follow doctor's instructions. And we don't use things that you're not supposed to use, especially after surgery. So that was an interesting finding I thought I would share. This is another case of, a kidney problem. So this patient has a history of kidney disease, was started on dialysis and was on peritoneal dialysis. And I don't know if you guys know, but peritoneum is like a cover in the abdomen, inside in the abdominal wall, which can also be used as a filter to dialyze patients. So this patient came in because he had abdominal pain and had fevers, and turns out that his peritoneum was actually infected. He had peritonitis, so they couldn't use that for dialyzing the patient anymore. So we started the patient on hemodialysis, so put a catheter in the vein. So we put a catheter, which is both in the artery and the vein. And then what the dialysis machine does is it takes the fluid out from the artery, from the vein, cleans it up, and then puts it back in the vein. Okay, so that's what it does. And it cleans up the whole blood and puts it back. And that's called hemodialysis. What we also do is the peritoneal dialysis. But in this patient, we were not able to do that because of the infection. And then the patient received peritoneal antibiotics. So we put antibiotics in the peritoneum, and that helped to heal it. And then after he got better, he was switched back to peritoneal dialysis and then went home. But sometimes these patients who get dialysis, the ultimate treatment for them is a kidney transplant, wherein they get a new kidney from another person after cross-matching it properly. So this was a patient. Many times, many patients have coexisting renal disease and have diabetes, hypertension, everything. So they come in with complications. But it's an interesting specialty. This is another case of an interventional radiology case I wanted to go over quickly. So basically this guy, he came in with leg pain, okay? And he noticed that his toes, the third and fourth toes of his feet were turning black. He had a history of diabetes, high blood pressure, was a smoker. And so there was concern that there was lack of blood flow in that area, and he had a gangrene, so he had a black toe. And then when we did Dopplers, we saw that he did not have any flow there. So we called the radiology doctors. They identified the site of the blockage, and then they opened up that blockage. So let me show you a picture that kind of explains that. So this is what normal vessels are. And then over time, plaque builds up. And then when it builds up to this level, then they start having pain because the blood cannot flow through. So what the interventional radiologists do under ultrasound guidance, so they are looking at it here while they are doing the procedure, what they do is they put in a catheter with a balloon. They inflate the balloon to open up this whole area, and then they put a stent in. A stent looks like this. It's like a mesh stent that stays in and helps to keep the vessel patent to allow the blood to flow through it. And then after that, we advise them to take blood thinning medicines and take cholesterol medicines. So that is an interesting thing. So if radiologists get together, this is what they look like when they take a selfie. All right. These are some terms if you want to become a surgeon. Ectomy always means that you've removed something. It's cut open and removed something. Plasty is always something that's been repaired, like rhinoplasty, things like that. Pexy is sometimes when you move one organ to another area, that's pexy. Ostomy is whenever you have a hole, when something has been opened, like sometimes the patients have colonic blockage, they put a hole outside and help the stool come out. That's called a colostomy, things like that. This is just a quick surgical. This is an interesting case. I had seen a patient who came from New York, had something interesting in his abdomen. He came in with abdominal pain. And when we saw, this was a bundle of heroin that he had just ingested to hide it. And then he came in with abdominal pain, and then it was extracted using endoscopy. It was such a cool case. I can never forget that. I just have a video of that case to share with you. So this is what it looks like when you looked at the CT scan taken in the axial way. That's what it looked like. And you could see the heroin pouch here, which tons of heroin in it that caused intestinal blockage. All right. And then sometimes you can never hide from a doctor because everything can be detected on the x-ray. So this patient came in and we saw this. When we did his x-ray, we saw this. And then guess where this was? No, it was not in his abdomen. It was actually lying on the stretcher. It was not inside his abdomen. It was lying on the stretcher, and we found this, and then we all panicked. And then we saw it lying behind him. So, all right. One of the last few cases we have is a neurology case. Aphasia means lack of speech, right? So anyway, we're going to go over two neurology cases. I'm going to show you quick videos. So this patient basically was a 23-year-old lady who came in. She had a history of seizure disorders, you know, where they have fits, and she was taking anti-epileptic drugs, but she stopped taking it because of some stomach upset. And then the family noticed this movement. So what this patient has is a generalized tonic-clonic seizures. So you can see that she has this involuntary movements. And, you know, she has, and then over time, if you see, she also starts having like jerking movements of the extremities also. And it ultimately like kind of gets, it lasts for a few seconds and then it resolves on their own. And there are certain medicines we can give them, which are relaxant medicines and sedative medicines, which help, just to get an idea about how this is. So the patient then started having like arm movements as well. Things like that. So this is a generalized tonic-clonic seizure that we saw. In children, sometimes there's another type of seizure called the absence seizure, which is very hard to detect. So this is just a case of that. I'm going to show you quickly. This boy, they are trying to get him to do some activity, and you'll notice in the middle of it that he stops doing the activity. And that is actually a seizure, believe it or not. And then now he's back to normal. So these are the different types of seizure disorders. They're detected by EEG. You also want to get an MRI of the brain to detect it. And then they have different medications that we use, like carbamazepine, phenytoin, valproic acid for generalized seizures, and lamotrigine and valproic acid for absence seizures. And sometimes you get seizures which go on continuously for 30 minutes. With some breaks in the middle, but the patient never becomes normal in those breaks. It goes on, and that's called status epilepticus. That requires ICU admission and requires a drip of that medicine continuously to prevent it. Those are some extreme cases, but those are the kinds we see in the hospital. Some other interesting scenarios we see in the hospital are patients that get agitated, and they sometimes need to be restrained. You know, they may be inebriated, they may have some drug use, something, they get agitated because of some psychiatry use sometimes, and they have to be restrained. Sometimes patients, elderly patients, they fall and they don't realize they're falling. So sometimes they have to have a safety belt. So this is just a safety belt, but this patient actually is restrained. But these are some situations we see, and preventing falls is an important thing we have to maintain in the hospital. Some other scenarios we see is correctional medicine, where we have patients from the jail who are in the jail and they get sick and they get admitted. Those are also some challenges because they can't work with physical therapy. We can do all kinds of tests on them, but they also need treatment. So we sometimes have to take care of them as well. Another interesting situation we come up with quite often actually is faking conditions. Patients come in and they fake conditions. And that's when we have to figure out whether they're actually faking it, whether they have a neurological problem, which just makes them have like a hypochondriasis where they just imagine things are happening, or if you, so sometimes it's actually a psychological problem, and sometimes they're just doing it for secondary gain. And the most common kind of things that they fake are neurological problems, because it's easy to say that you're weak in one hand and not move it, right? It's easy to say you have numbness. It's difficult to test it. So those are some challenges sometimes we face in medicines. And there are some tests, like there's this Hoover sign that we use to detect those as well. So those are some of the things we also do. This is another fun case. I don't know if you guys can see. Patient was missing something precious, and we tried to find out where it is. Can you guys see where it might be? This is a earring. The patient's earring is lodged in the ileocecal valve. And actually, this was important because if we did not do anything about it, it could have perforated and caused a hole into the gut. And then all the intestinal contents could have spilled out. So actually, this patient needed to get lots of medicines to get the stool out. So it was getting a lot of laxatives, and then we got it out. All right. Some other issues we have are ethical dilemmas. There are patients who don't want blood transfusions, and then they come in, and when they come in with those things, then it's difficult if they come in with an emergency, like this patient who came in with an artery aneurysm that ruptured, and the patient was going to get blood transfusion, undergo surgery, but the family called and said, oh, we don't want this patient to get blood transfusion. So those can be situations which are difficult that we have to deal with. Another ethical dilemma we come across sometimes, and this was one case that was listed in the New England Journal of Medicine, where a patient came in with alcohol use and he was not responsive, he was not able to talk, and he was initially admitted but then got worse and had to be in the ICU, and they had to intubate him, and when they opened his chest, they saw the sign as a tattoo, and it said, do not resuscitate. So at that point, we were at an ethical dilemma because we didn't know what the patient wanted. He couldn't communicate. He had no family members, but we didn't know whether to resuscitate him, because if we did not, he would die. And then ultimately, we consulted the ethics department of the hospital, and they recommended to follow the patient's instruction because it was so obvious. And then the patient did die. And subsequently, we found in his paperwork that he did want to not be resuscitated. So we did what was in the patient's interest. But sometimes these ethical dilemmas come up too. Some good medical books I would really recommend reading, especially this one, How Doctors Think. It's one of my favorites. It's a great read for anybody, and it really helps you how to help a doctor help you make a diagnosis, because many times the patients are the ones who give the symptoms and the history, and the patients can be good history providers that can really help the doctor. So that's a great read. I would recommend that. And then there is this book, Checklist Manifesto by Atul Gawande. He's a lovely medical author. And this is a great book on how important checklists are to prevent medical and diagnostic and treatment errors in medicine. And then, of course, the inevitable, patients do die, right? And what do you do? How do you diagnose death? You want to make sure they're not breathing, want to make sure they're not responding to verbal stimuli. You want to look at their pupils. They need to be fixed and dilated. You want to check their pulse, that there's no pulse. Sometimes you don't know if they're breathing or not. So a good idea is to put a mirror in front of their nose. And if it fogs up, they are still alive. If it doesn't, then they are not breathing. And sometimes patients fake death, believe it or not. In that case, you put a pungent onion in front of their nose. And if they move around, they're not dead. But that's basically, that also happens, and we need to know how to deal with it, talk to family members, and also we have to ask if they want an autopsy. And if there is an autopsy needed, then we contact the forensic department in the hospital. All right. Another thing that we do, remember I told you in the beginning, we sometimes get rapid responses when patients are very sick and need to be assessed quickly. That's me attending some rapid response in an older patient, where everybody goes in quickly and tries to evaluate the patient and help. Sometimes they need resuscitation. And remember, the resuscitation leads that we use have multiple purposes. You can also use them to make sandwiches because they produce so much heat. No, I'm just joking. Don't you do that. Okay. All right. We also do a lot of, education. We come across interesting cases. We try to publish them, things like that. These are some of my publications and presentations. Also, we are actively involved in medical student and physician assistant education. So we do didactics workshops. I'm also director of the 4th year clerkship. So we are involved in that as well. We also teach them how to do procedures like line placement on these kind of models. So these are some models that we have in the hospital, in our SIM center. We use ultrasound. We show them how to identify the veins, and then we show them how to put in the needle into the vessel. And then that's where you see that the needle goes into the vessel. We show them how to do that in these mannequins. And if you just want to see what it actually looks like in real life, this is a video of how actually it looks like in real life when we're doing it, where the patient is cleaned and prepped in a sterile fashion. We're doing the ultrasound, and then this person is injecting inserting the needle, and then it's in the blood vessel. And then we put the other catheter and everything through it, and you cannulate it. And that's how you get an IV access if you need a big access. Otherwise, a small access is placed by the nurses. The other thing that's important for all of us is our own personal, professional, and career development. So we do have hospital medicine fellowships. We have other scholars program. We attend conferences annually, CME conferences. That also is helps with our overall education. And then on the site, we do like risk management training, coding documentation workshops, and quality improvement. That's a big emphasis as well. The coding and billing is important because whatever we've seen with the patient, we write the codes for those particular conditions and then we bill based on the complexity of the patient. And that's how the insurance company reimburses the hospital for the payment for these patients. This is our fight against COVID. That's me in my COVID garb. And the COVID disease mostly is related to blood clots and thickening of the lung, fibrosis of the lung. So you can see blood clots here. We also have been seeing new cases of toes being involved, where there are blood circulation gets affected in the toes. And the recent new problem with COVID is mucormycosis, where we are seeing fungus, moldy kind of fungus that's developing in the nose because patients are always on steroids, which reduces their immunities, and they're wearing dirty masks. So that also causes this fungal infection. So that's a new problem we are dealing with now. Just a quick idea on what the hospital is like. So this is a medical center. It has an ER. It has a birthing suite here, the women's center. It has like a medical buildings, and this is a surgical building. This is what a medical center looks like. And in the hospital, we have different floors, people located in different areas. This is the entry of the hospital. This is where they do lab work. This is the heart station where they do echoes and EKGs. This is the CT and MRI unit where they do CTs and MRIs. This is where they do ultrasounds. They do radiology. This is the surgical suite where they do operation and theater. This is the birth and labor suite where they do deliveries. Of course, there are patient rooms, which are shared rooms, private rooms, ICU rooms, things like that as well. But that's the general structure of a hospital. And these are the different committees that we get involved with. Some of these are risk management is an important one, quality improvement is an important one. Then we have a blood transfusion committee. We have an ethics committee, which is important. And then we also have the training physician related committees, which are health staff related committees. And then our goals, like, every hospital is monitored in US by a joint commission of accreditation of hospitals. These monitor patient safety. You want to make sure you're identifying patients correctly. You're not giving wrong meds to the wrong patients. You're making sure that the communication is effective with them. The medicines are given with safety. We're not giving medicines that interact with each other and cause complications. Want to make sure their bed alarms and other alarms are safe, making sure the infections are prevented, and preventing mistakes in surgery. So these are some like common patient safety goals, which JCO always emphasizes, and they monitor us very closely. If we make any issues, they stop us from providing patient care. This, of course, is a prescription for mindful living. Always make sure you get good sleep, stay happy, be confident. And so our hospital is actually happy. Yes, we are. Many surveys have found 75% of people are actually quite happy with their career because of the flexibility in schedules. The main thing is that we burn out because there are long days in the hospital, so you feel the burnout, but because of flexibility in scheduling options, remember we work only 26 weeks in a year. The rest of the time you have off. And for me, sometimes it's even lesser because we do other teaching. So we get some extra time off for the teaching we do. And plus, because I have training providers under me, so they come and they do the work. So I don't even have to be there from 7 to 7. I can go there from 9 to 6. It's great work. Love the job that I do. And if you have the right group leader and right director, it's a great way to work, especially it's great work and life balance. I just love it. I'm super happy. Of course, like any situation, everybody has challenges, the healthcare systems here, the aging population, obesity, mental illness that occurs, all those are challenges. And medical advancements, the cost of medicine just goes up with these advancements, although they're good for patient longevity, but that does cause problems. Now, malpractice doesn't happen so often in hospital medicine, but it does happen when you make diagnostic errors, when there are communication issues. Many times it's because you've not documented enough. And another time it happens often is when you don't transition care properly, like when patients are being discharged from the hospital to the house or from the hospital to another rehab center, the transition of care has to be smooth. So all the information needs to be relayed properly, things like that. That's where errors can happen. But by and large, it's a relatively safe field with very low incidence of malpractice. So another reason to do it. And then we get paid mostly it's salary plus depending on your productivity, how many extra patients you see, how many extra procedures you do, procedures pay more, things like that. There is more incentives for you. So that's how we are paid. And these are some fun times we have at work. This is one time when we had an all ladies team. This is outside the hospital where I work. And this is my family. This is my whole family, my husband, my 3 kids. This is my oldest going to Duke this year. So excited. These are my kids on Mother's Day, and this is my mom and dad who live in India, and they are doing great, thankfully. These are some of my hobbies. I like to volunteer at the DC Central Kitchen. I like gardening, and I like sewing, other than the regular cooking and other chores that we need to do. And one of my favorite hobbies is bungee jumping. That's me doing bungee jumping, and I also like Bollywood dancing. All right, and this is the Hajj pilgrimage that we went to with my family members. And these are some volunteer activities I'm involved in. This is the eGlobal Health, eGlobal Doctors. We're part of the group that provide care all across the world virtually, more so active during the COVID crisis. This is me vaccinating at one of the healthcare facilities. And this is some of my colleagues. We're in the news. My colleague is a military professional. She works with the Air Force, and she was recently deployed. And this is some awards we've received. And this is one of my co-physicians who received the Washingtonian Top Dog. This is a favorite channel. I would recommend this if you are interested in following any medical channels who talk about like day-to-day medical things that come up in the news and other things. This is a good one to follow. And let's end by seeing if you can recognize emojis, medical emojis. Anyone can guess what this is? Pneumonia. Well, this is the way to say you're going to get diabetes. All right. And this is how you can contact me for any questions. Thank you for listening through, and I'm open for any questions and answers.
Thank you, Dr. Izzi. If anyone has any questions, they can feel free to ask now. We will now begin our Q&A session.
You can save this PowerPoint in case anyone wants to see it. And then if anyone wants to email me about it later, you're very welcome to email me as well.
Thank you very much for that incredibly informative session, Dr. Izzi. My name is Hamza, and I'm from New Jersey. I'm matriculating into a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine in Pennsylvania. So to start off our Q&A, one question we had was, how would you personally define quality of life when determining whether it's worth saving a patient, and what are your thoughts on euthanasia and comfort life measures in the United States?
Yeah, so that's good. I didn't talk too much about comfort, but yeah, comfort, we don't do euthanasia. I mean, we don't try to, unless the family requests it, we don't generally do euthanasia in the hospital, but we do try to talk to patients' families if they are trying to do things that are not appropriate. We involve a palliative care department. They help with end-of-life comfort measures, and they're excellent at talking through things, helping the patient's family put themselves in the patient's shoes and decide what would be the goals of the patient should the patient be alive. So that helps so we don't actually practice euthanasia, but we do comfort care, especially patients who are terminally ill, who have end-stage cancer, who've had like multiple strokes, that they're just a vegetable and we're just prolonging life for no meaningful recovery. For those patients, yes, we do comfort care and we do try to advise the family, but we don't do anything against families' requests. That's just with the hospital policy. I hope that answers your question.
Yes, that does. Thank you. Can you tell us more about what you do as an assistant professor and how the medical school clerkship works?
Yeah, so the assistant professor, that's mostly like a role from the medical school. So the medical school has multiple years, right? So you're in 4 years of medical school. The first 2 years are mostly teaching based, and the last 2 years are more clinical based. So I am the director of one of the 4th year medical clerkships called the Medicine AI, which is the Medicine Acting Internship. That's done in the 4th year. And in that clerkship, the students they come, they rotate on the medical wards, and they act like interns. They do all the roles that the intern would do once they become a resident and an intern. So that's the clerkship that I direct. So we arrange for their speech, for their lectures. We arrange to make sure that they have we assign them to different teams, and then they take care of patients on the different teams. And then at the end of it, we do their evaluation and grade them and things like that.
Thank you. How do physicians treat conditions or complications if there's an unknown cause or idiopathic?
Sorry, tell me again.
So how do physicians treat conditions or complications if there isn't any known cause?
So if there is, you're saying like if there is no cause for the condition, how do we treat it? Or you're
Like
asking
if there's
a
no known
complication?
cause, you can't figure out why it's happening.
Yeah, so many times when they come in, like our main thing is to identify and rule out the fatal conditions, right? So if a patient comes in, has abdominal pain, and then we've done their endoscopy, colonoscopy, abdominal CAT scan, we've done a gastric emptying study, we've looked at everything. Of course, now it cannot be anything life-threatening. We've ruled out all the life-threatening conditions. At that point, we just explain to the patient that, look, you have this pain, we're not able to find a condition, but we can assure you that there is nothing life-threatening here going on. And then we explain to them and then discharge them, and then they can follow up with their clinic, because many times these conditions, they don't show up in the beginning, but over time they declare themselves. And then when they declare themselves, that's when we find out. But our main role is to rule out all life-threatening conditions and things that are treatable in an urgent basis. And the rest is all done as an outpatient.
Thank you. That answered the question. Next question we have is, how much studying do you do as an internal medicine physician? Do you use informational sites like UpToDate, Medscape, or Hippocrates?
Yes. So we use UpToDate often. And of course, there is always new stuff that comes up. We can never know like everything about everything. So we do use UpToDate is commonly used. And then we also use, what's the other thing? We use Medscape often, but some hospitals do provide UpToDate subscription. Ours does not, but all of us have, like, we use PubMed for other things. But yeah, we do use it. And oftentimes we have, like, because ours is a big hospital, we get referrals from other places also. And we have all kind of service providers in our hospital. So many times if we just have a question, we call an ENT doctor and we're like, oh my God, I have this patient with mucormycosis. What do I do? So sometimes it's just like word of mouth, but of course, UpToDate, we can't live without UpToDate nowadays.
Thank you. The next question we have is, what are some types of clinical research you have been working on in recent years?
So I don't get much time to do active clinical research because I'm very actively involved in education and clinical. But because of this new opportunity of COVID, now that's a new condition. Lots of things have not been known about it. So this has been a great opportunity for us. And we've published 3 papers already on different things that have been going on. So a lot of my research is clinical, not really lab research. But for COVID, we've published one paper, which is like on what markers predict worse outcomes in COVID. And then one we've done on what abdominal symptoms do patients come in with COVID, what GI symptoms they come in with COVID, and things like that. And the one that I did with COVID and medical education recently, and that's just been presented 2 weeks ago, that is how to do virtual teaching, how to do virtual rounds with patients for the students when they're not able to come in, because there were like a few months earlier on last May when the students were barred from coming into the hospital. So at that time, we did virtual rounding. So how we did the virtual rounding, so we wrote up that study, and that's also what was presented, and now we've submitted it for publication. So those are some of the things we do currently.
Thank you. Next question we have is, how would you describe your work-life balance as an internist?
Oh, it's amazing. I just mentioned, right? Like, it is amazing because we work only 26 weeks off the rest of the week. So that's great schedule. So the weeks that I work, I'm busy. The weeks that I'm off, I'm doing all the other house chores. And then the weeks that I'm working, my husband kind of takes the lead. So it's a very well-defined structure. It works great. Children also used to that. So works great. And it's very doable, especially in academics. What happens is my hours also are not so long. I can go in by like 8:30 and I'm out by like 5 or 6. Of course, there are going to be emergencies because this is a field where we have emergencies, urgencies, everything. So there are going to be some times when things are late, but that's the nature of our business. And my family knows that, and they respect that, and they appreciate that. So that works out great. And the rest of the time that I have plenty of time to do volunteering, to do house chores, to do housework, to do upgrades on the house, to travel, everything, plenty of time. So that it's a great thing, especially for women. I think men also, a lot of my colleagues are men. We actually have only 3 women in the department. So men also love it because they get a lot of free time. And people who are single, they use all their free time to travel. And compared to internal medicine, primary care, hospitalist pays much more. That's another incentive to go into hospitalist.
All right, our final question is, what is your view regarding the long-lasting COVID lockdowns in relation to mental health, especially for future generations?
It's a big issue. It's a huge issue. And especially even COVID patients that I see on the floor, when they're in the room, they're in the hospital for like 10 or 12 days, they get depressed. They get depressed. Like if you put somebody in a room where nobody comes in, you're kept in isolation, you don't have taste, you can't eat food, you're short of breath, always huffing and puffing, everything is aching, you're alone. It has a terrible impact on mental health. We are seeing lots and lots high cases of depression. You would have seen a lot of my cases have schizophrenia, depression on them because mental health is a big burden in US and in other countries as well. And but I think we have been very proactive about it. And because we expected this to happen, when patients come in, we do give them some sedatives, we give them good sleep medicines and try to make it as comfortable for them as possible. We're trying to avoid it, but I do expect that the COVID is going to cause more mental health issues. And we just hope that our psychiatrists are able to come up with ways to deal with them. And there is a great need for psychiatrists as well.
Thank you, Dr. Izzi. Those are all of our questions.
Thank you very much, Dr. Izzi. We truly appreciate you taking the time to answer our questions. I'd love everyone to please give a warm thank you to Dr. Izzi in the chat box for this incredibly informative session.
Awesome. Thank you, guys. And feel free to email me anytime. There's never a silly question and there's never a wrong time. All right. And good luck. And I hope to see you all as hospitalists.
Thank you, Dr. Izzi. The link to the quiz for this session is now live. Again, you'll need a 70% or higher to pass and receive certification. Now on to our next session dates. I'm looking forward to seeing you all at our next session next Saturday on May 29th at 10 a.m. EST, Eastern Standard Time, with our physician mentor specializing in pulmonology. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions as well. This concludes this week's shadowing session.